Good afternoon, everyone. I love this engagement already. My name is Paul Surgener. I'm the National Director for Information, Support and Education here at NAMI. I'm delighted to welcome you here to our webinar today, Improving Mental Health Care Through Inclusion and Compassion, Lessons from the Field. This is a webinar. You're spoiling my surprise. So, Ask the Expert is about sharing experiences, asking questions, and learning from each other. So we have this not only from our expert speakers and panel today, but also from your engagement, your experiences, and from your questions, so we can learn from each other. This webinar is particularly exciting, not just because of the panel we have here today, but this is the first time we're doing Ask the Expert online as a webinar, but also live from our convention here in New Orleans. So for everyone who's listening online, we have about 600,000 people in the auditorium here today. You can hear how many there are. And how this is going to work is in a few moments I'm going to pass you to our MC for this afternoon. He's going to introduce our presenters. They will talk for about 10 minutes each. And they will then have an opportunity to talk to each other and to share insights so that we can get as much information from as many different perspectives as possible. As always, we're going to have a Q&A, and this is both for people who are online and who are in the room. If you're in the room, we'll have our mic stands just here. If you're online, you just type your questions into the chat pod. I would ask, could everyone hold your questions until the Q&A session at the very end? Okay, so without further ado, I'm going to introduce you to our MC. Everyone here who has ever heard of NAMI has heard of our medical director, Dr. Ken Duckworth. So I'm going to pass you over to Ken now. Ken.
Hello, everybody. Welcome. We're trying something new, which is part of the fun of NAMI. So we're doing this online, so some of the questions will be coming from people who are participating online. Please organize your questions for the end. So mental health care needs a lot of love and help in our modern American society. If any of you got to see the British gentlemen that were here to speak from London on their work in cognitive behavior therapy, you can see that we have a long ways to go to emulate our colleagues from across the pond. We're very fortunate to have 4 experts in different perspectives. And I'll be introducing each of them as they come up. Our first speaker is Terry Bridges. Terry's a longtime friend of our mission. He volunteered as a teenager at a state psychiatric hospital. Flash forward, he's the president of one of the largest services at the Hospital Corporation for America. He's now retired and is quite engaged in NAMI and in his local community. And please welcome Terry Bridges.
Hi, everybody. Thank you, Ken, and thank you for the invitation to join you today. I hope in my brief time with you all, I'm able to convey how important collaboration is to our mission of compassionate care. There's nothing more important than that to me. I want to do this from a provider perspective. I want to share things in 3 ways with you. I want to talk about sort of the provider environment, just to give you some context of the care. I want to talk about the critical role of NAMI. There's no bigger believer in NAMI than me. And talk to anybody who's worked for me or with me about what that means. And I want to give you some good examples which I think help convey what the collaboration can be to get us where we want to be with our loved ones and families. So let me start with talking about the provider environment a little bit. And this isn't to get sympathy, but just to give you a context for the care that's being delivered and where the providers are coming from often as you interact with them. One, and I'm going to tell you some things that most of you probably know and you've heard time and time again, but you know, the provider shortage is one thing that worries me probably the most. Half the counties in the United States don't have any access to psychiatrists, social workers, psychiatric nurses. have no ability to receive care in that context. There's some work being done with telepsychiatry. It's a filler, not quite the same. But that's a huge issue. As we deal with that, then we're dealing with the psychiatrists who are aging out. The average age psychiatrist is close to 60, and there's not a wellspring of new psychiatrists coming up behind. And of the psychiatrists we have, half of them often don't take insurance. They are in private practice. They have waiting lists, and it's not a service to the general community that we all are interested in. Coming from the acute care side, one of the challenges we've had is just staffing units. Oftentimes our ability, our capacity is very limited just because we don't have enough, not only doctors, but nurses, sometimes social workers. And so we're in an environment where we really have to figure out that whole workforce piece. And we got to get more people inspired to do the work that we all believe in so deeply. And we all know that in terms of our environment, and the workforce issue is for those that have funds or no funds, but that's a common issue. But for those who are unfunded, we all know that our safety net was compromised in the Great Recession, start of the Great Recession. We know we lost over $4 billion of state mental health benefit or funding, and we lost close to 4,000 public beds. For those who don't have the ability to pay primarily, and so with that, what became the de facto safety net for our communities? And coming from the hospital world, this is a hot button issue for me, but it's the emergency departments in each of our communities. And that we know, all of us know deeply, that is no place for someone in mental health crisis, is to be in an emergency room. And I'll come back and talk about some of the things that we did to try and address that. But just as a little brief insight, one of the first things when I came to HCA to help reinvigorate their behavioral health services, and HCA, the largest hospital provider, private hospital provider in the nation, one of the first things I did was I went to a conference to talk about behavioral health to 80 hospital CEOs, CFOs, and chief nursing officers. Out of the gate, the first presentation that was made was a medical director for the EDs that said, first statement, we got to get the psychiatric patients out of our EDs. They're chasing away my nurses. And so I'm sitting there thinking, well, let's see, my presentation's about 3 or 4 from here. Let's see where this goes. But time again, it was about the concerns, the issues psychiatric patients were presenting for his staff, not thinking about the compassionate side for the patients, but thinking about the staff. 5 presentations later, my partner and I get up, we talk about behavioral health, we're talking about the epidemic or the crisis of demand and the lack of resources and shortage and the lack of compassion. And he came over to me afterwards and apologized and said, we'll do things differently. So there is room to make a difference with that. At HCA, we had over 200 EDs, and just a sense of what that looks like. We had over 8 million. This is data that's probably 3 years old now that I'm retired, but I think it still holds in general. We had over 8 million visits that year. And of those 8 million visits, 1.8 million of them were patients that had some form of behavioral diagnosis. And so how is it our emergency departments can't be well prepared, equipped to deal with one of the most common issues they're having to deal with when they come in? So, and again, we'll come and talk about that, because I think what we did with that is one of the reasons I got invited to stand before you today. One of the other challenges that we have from the hospital and treatment provider community is, how do we take care of the whole person? I was listening to Patrick Kennedy talk about somehow doctors haven't figured out that the head and the body are really connected, and we got to take care of the whole person. And we all know that that those who are experiencing mental health diagnoses have a life expectancy far below those who don't. And we know that when we have behavioral patients in our hospitals, that 2/3 of them have medical comorbidities, medical issues that need to be addressed, that oftentimes in freestanding hospitals can't be. That's why I was excited to move into the med-surg arena. And in talking to our CEOs who often said, I don't really want psychiatric patients, I said, well, you got a medical floor, right? And they said, yeah. I said, well, do you know that over 1/4 of your patients on your medical floor have behavioral comorbidities? So if you have an ED, if you have a medical floor, you're in the business of behavioral treatment, if rather you want to be or not. So let's just do it right. And so that's huge. But and there are some pockets, and when there's reimbursement opportunities where you can go at risk and you can manage by episodes. There's been some folks that have done some good work with integration of care. I think Providence in the Northwest and Baycare down in Tampa, Montefiore in the Bronx have done some good work, and they've shown some good outcomes where you can see where the patient experienced better care, had better outcomes, lowered costs, had less readmissions, and so it just makes sense to do that. So why doesn't everybody do that, right? Well, the reason not everybody's doing it is because of the way the reimbursement system works primarily. You have behavioral health benefits largely carved out, and it's very cumbersome to try and get the coverage and the payment for that patient. But also you have the staff shortages, and there are a lot of doctors are fearful that if they order a consult, a psychiatric consult, that they won't have the ability to provide the adequate treatment, and it's a liability for them, so they'll just defer it. And when you defer something, you know what happens. It oftentimes goes untreated. So we've got to do better with that. Now, Medicare is coming up with a bundled payment system, and they've identified this, and they're doing it with some joint replacement and some other things, and it'll be rolling out across all the medical diagnoses. They haven't figured out how to do that for behavioral yet. Some of you may know more about that than I do right now, but what it is, it's a bundled payment where somebody convenes all the providers and you get one payment for the episode of care. Well, that's going to be great for behavioral patients, because those with behavioral comorbidities are the ones that drive the costs up, because they're the ones that typically readmit or are less compliant with their medications and have less favorable outcomes. So they've got to treat it now. To be able to get the outcomes and to get the efficiencies that they need, which is sort of an unfortunate way to go about it, but we'll take it. We'll take that, and then we'll figure out how to get bundled for the episode of care for behavioral at some point. The payer community, and again, I'm preaching to the choir on much of this, I'm sure. Payer community, we know that we're thrilled with all the parity legislation and regulation that got passed. But we also know that it's not being enforced. And talking to Andrew Sperling, the NAMI legislative advocate and lobbyist, talked about, he just was with Patrick Kennedy in the forum, and they're trying to get a certification so that insurance companies have to comply and they get certified that they actually are providing services and access and utilization, management and review in parity with medical diagnoses. So we'll hope that that continues to move, because right now access is restrictive. The patients are being pushed out before they're ready, and without the adequate amount of outpatient resources to fill the gap. And the providers are also getting denials of care retroactively, even though they had initial authorizations, which is just crazy. So we're in a world where that needs to get straightened out. And I think most of you are probably familiar with the IMD exclusion, the Institute of Mental Disease, where adults with Medicaid don't get reimbursed if they go to get care in a freestanding hospital. And so recently I just read where the House passed a repeal of that. They've been working on repealing this for 20-something years now, plus. And we're hoping that goes through, because what happens in the communities, and I feel like I'm going to be going on far too long here, but I'll speed up. So, in our communities, what happens is, because a person can receive, a young adult with mental illness can receive treatment in a med-surg environment, all the Medicaid, which is typically very poor payers, go to the med-surg hospital. All of a sudden, they're seeing that they can't make any money because Medicaid doesn't really pay them full costs, and then they end up closing beds, and then the freestanding hospitals are out there with better payers, doing better, and not taking their share of the community need. And so we end up without access again. So we got to get these things kind of straightened out. HIPAA laws, just to throw that out there, we know how, even though it's intended to protect our privacy, which is great, but when a patient shows up in the emergency department and we can't talk to the family about the patient's history, clinical picture, and that sometimes we're flying blind, and if there's going to be an incident in a hospital. That incident usually happens in the first 48 hours when we're trying to assess a patient and have, trying to get up to speed where they are, but that's when an incident will happen either medically or psychiatrically. And so, I know I was just talking to Mary, and they're doing some work trying to figure out how we can have more interaction with families to give the clinicians and the care providers the adequate information they need to take care of our loved ones. All these challenges are out there for the providers, and that's sort of the context that people have to operate in trying to give the adequate care in some of the most intense, anxiety-ridden times of a person's journey. But I'm very pleased to say that and you've been hearing this through a lot of the presentations, I hope, that providers have really been rising to the occasion and trying to stay focused on evidence-based care, patient-centered care, trauma-informed care, providing CBT and DBT in ways to really give patients in the short amount of time they have adequate tools for recovery. And we've seen huge drops in, if not annihilation, of seclusion restraint. It's a rare occasion if it ever happens in a hospital these days, which I'm thrilled with. And so the levels of outcome and recidivism, all that, there's been huge strides made around that. So I think we're going the right direction, but it's a tough environment, and this isn't about whining about the provider engagement, but it's about sensitizing, because this is really about how badly we need NAMI, to me. And let me tell you how I think about NAMI. I believe NAMI is the tie that binds us all together. I'm just on that very short front end side with the acute care, but then there's the ongoing, there's the ongoing issues that lay out there about continuing care, outpatient care, all the support that needs to happen. And NAMI helps us get there. We're a fragmented environment, and they can help pull us all together. They speak with a pure and powerful voice to the people that need to hear in the payer and political environment. Examples, I just got my flag, so let me just give you some quick examples of some great things that have gone on. And I was invited because out of a conversation I had with Mike Fitzpatrick, who preceded Mary, and I asked him at a corporate support meeting, where are the other providers? Am I the only provider here? And he said, yeah, we need more. And I said, well, how's NAMI thinking about us these days? And he said, well, there's been a lot of improvements, but there's a lack of respect is a common complaint I'm getting. So I said, we have all the EDs, let's work together, and let's come up with some trainings for ED staff that will help address the issues that our folks in mental health crisis are experiencing in emergency departments. So we did. Joyce Berlin was assigned to us. We got 3 NAMI members talking about their lived experiences. We did a vignette showing the right way, the wrong way, and it's been dynamite. It's gone viral across the country. We show it every day. I just checked with our people at HCA that were here. They embed their management team, by the way, in this conference so they can stay focused on who they serve. And they assured me it was still being actively used in all the EDs. And so, that's just a piece, and that's not a total solution. It's just one aspect of what we need to do over and over again. But quickly, let me just talk about other things that we do. It's much more. We love NAMI walks and we love supporting NAMI, but it's much more in supporting NAMI than participating. It's about joining and really truly partnering. We have the NAMI director of Davidson County that goes to the HCA hospitals and orients the staff about lived experiences that NAMI's families have that they need to be sensitive to when they're caring for patients in their hospitals. That's part of the routine. And 2 things just real quick. We have a young lawyer that talked about a NAMI-sponsored group on the unit that was sort of a peer-to-peer experience that connected her with NAMI forever. She's now a trainer with NAMI. We have a NAMI in the lobby experience with our new Kentucky Hospital for Sudden Behavioral that opened up that helps places NAMI volunteers to help assist families with their visitation hours and coaching them on visitations, even visiting with patients who don't have families. So long story short, there's so much we can do. We joined with the Dallas Police Department in Dallas and with Green Oaks Hospital to help sponsor CIT and promote CIT. I just believe that together we collaborate, we can do great things. We can bring the compassion, we can improve care, and I believe NAMI is just a foundation of that. Thank you.
Thank you, sir. Our next speaker is a psychologist. Dr. Lisa Strayfeller is the chair of behavioral medicine at the Des Moines University College of Osteopathic Medicine. As a licensed psychologist, her clinical interests include trauma and caring for women in the postpartum and pregnancy stages of life who are living with a psychiatric illness. Please welcome Dr. Lisa Strayfeller.
Thank you very much. So I was asked to talk a little bit about how do we think about inclusion and how do we think about compassion in a medical school framework? What are some of the threats to it that we try to figure out how to address? What are some of the ways we try to get over those challenges? And talk just to give you just a taste of something we're going to talk about a little bit more tomorrow, but how my medical school has partnered with NAMI to bring the NAMI Provider Education Program to our students. So probably none of you have heard of Des Moines University unless there's a hidden Iowa crowd here that I haven't seen yet. Excellent. Yes, some of you know exactly who Des Moines University is. We're a graduate health science university. So we teach a variety of healthcare practitioners. So we teach students getting their DO or their Doctor of Osteopathic Medicine. We teach folks who are going to become doctors of podiatric medicine, physical therapists, and physician assistants. But our largest cohort is the group that are going to become osteopathic physicians. And how many of you have ever seen a DO as opposed to an MD? Okay, we've got close to half, it looks like. So for those of you who maybe don't know where osteopathic medicine comes from, at this point in history, there's a lot of overlap. So the licenses are pretty much the same. The things that a DO can do are pretty much the same as what an MD can do. But there's a difference in history and probably a little bit of a difference in attitude as well. So osteopathy comes out of a very intentionally holistic view of patients. So there's this idea that patients can become well if you nurture the body's inherent capacity to heal, and that you shouldn't just look at symptoms, you should look at the whole person, right? You should look at the person's body, the person's mind, the person's spirit, and figure out how can we maximize this person's capacity to heal. So obviously this is a very natural fit with asking our medical students and then as they become physicians to think about, okay, how can we provide better holistic care? How can we help patients who might be living with schizophrenia or might be living with bipolar illness, and maybe they're coming in for treatment of those illnesses, but maybe they're coming in for treatment of their high blood pressure, or maybe they're coming in for treatment of their diabetes. How can we help our students think about this whole person and everything that they bring to the table? And that's a big part of what we teach and what we do at Des Moines University. And then the other piece I think that's significant about who we are at DMU is that a really large percentage of our students end up going into primary care. And in fact, in the past year, Des Moines University produced more family medicine physicians by the numbers, just sheer number of family med docs, than any other med school in the country, either osteopathic or MD schools. So a whole bunch of our students want to take care of people kind of across the broad spectrum. They want to take care of kids, they want to take care of adults, they want to take care of seniors, they want to take care of their ear infections and their diabetes and their depression or their anxiety or whatever the other challenges are. And so we got interested in how do we help not just our students who want to go into psychiatry, but our students who want to be family docs, or our students who want to be pediatricians, or our students who want to be internists or emergency medicine docs. What can we do to help them? So as we think about what are the challenges that face our students, we know that our students come into this by and large because they want to help people. And pretty much if they don't say that in their interview for med school admissions, we don't take them, okay? We want people who are motivated because they want to help others, and this is why they want to become a physician. Yes, we screen very thoroughly on that. But not only do they want to help patients, they like to fix things, okay? Our students are largely fixers. They like to fix problems. And so when they can't do that, when they don't have the resources or they don't have the knowledge or it's a problem that's not amenable to being fixed, it's frustrating for them. Or when their attempts to fix the problem get rebuffed by the patient for whatever reason, whether that has to do with mental health or whether that has to do with economic barriers or any of the other myriad reasons why a patient might not be willing to jump up and say, yes, I want to do exactly that treatment plan you've just laid before me, then that can be frustrating for our students. So the good part is they really want to make people's lives better. The bad part is they don't always deal with it incredibly well if they don't have a clear path to being able to do that with their patients. We also know that medical personnel have their own issues, right? And I think when you're on the patient side of the examining table, it can be really easy to perceive physicians as invulnerable, right? They're the ones with the power in the situation. They're the experts. They're the ones who should know the answers. And it can be easy to not notice ways in which they might feel powerless or ways in which they might feel vulnerable. And in fact, we know that rates of professional burnout have been going up among physicians, certainly in the United States, but actually globally. Up to 50% of practicing physicians report significant issues with burnout. There's an increased likelihood of dying by suicide among physicians. Obviously, estimates are hard to come by and they can vary, but probably at least double the risk of the general population. And you would think that physicians would have easier access to good mental health care, right? So they're doctors, they probably have a reasonable income, they're probably insured, they should know the system, they should know where to go, but actually they don't, okay? The barriers to accessing mental health care for practicing physicians are enormous, and there are a couple of them. So first of all, if you want to be licensed as a physician and you want to renew your license, the medical board is going to ask you questions about your well-being, and these vary by state. But in some states, these questions can be along the lines of, have you received treatment for mental health care in the last 2 years? And if you have, then you can be referred to a physician health board, which varies a lot by state, and some of them are pretty hostile. And some of them can say, you know what, if you got that kind of care, then we're going to watch you more closely, or we're going to put additional regulatory burdens on you. And the fear of that is enormous around both mental health care and then care for substance use disorders. The fear is enormous among practicing physicians, but also among our med students. I've taken to putting up the licensing board questions that they will have to answer on a PowerPoint slide as I lecture to them, because they're asking me about that now. What happens if I seek care for my depression? What happens if I seek care for my anxiety? What implications does that have? So there are fears around licensure. There's also professional stigma. So there's this really strong cultural rule within medicine that you should just suck it up and keep going. And it's been really interesting for me. So my training as a psychologist actually is not like that. So when I was in grad school, we would sit around and we would chat about who the better psychotherapists were in town. So if you needed help, go see this person, but don't go see that person, right? Normal, acceptable, appropriate thing to be doing. Not among our med students, okay? You should be able to handle it, and if you can't handle it, maybe you shouldn't be a doctor. So the stigma is enormous around seeking help. In ways that it shouldn't be at all, and in ways that we actively work on at our med school and at other med schools, and this issue is gaining traction nationally. But it's a significant problem. So physicians are less likely to seek care for mental health problems. Obviously, workload of most physicians is very substantial, and the time demands of electronic health records have become enormous, and they both expanded physicians' workdays, but also pulled them away from patient care. So doctors will talk about how it's more important to take care of the eye patient, the imaginary patient that lives in the medical record, have you clicked all the right boxes, is more important than the human being over here, because you get paid based on the eye patient, not based on the real human being. And then the final issue that I want to lift up that we think about and talk about with our students and with physicians in general is we can forget the human toll of practicing medicine, right? You go into medicine because you want to relieve human suffering. But what about when you make a mistake, right? What about when something you do causes harm to one of your patients? The emotional burden of medical errors for physicians is enormous. Or even when you do everything right, what if your patient still doesn't get better? You know, obviously the burden of that on the patient carries the primary burden there. But when that happens for physicians, the emotional toll of that is significant. And so those factors, when not addressed, lead to less compassionate, less inclusive care, right? Because what can happen is when students are exposed to a system that's overburdened and under-resourced, it can be really hard to not get cynical. And you throw in they're working too many hours, they can't get help, and they think they're bad people if they're struggling as a result of it and they can't talk about it. Then they take a step back and they get kind of cold and they get the kind of care that being provided that nobody wants to see. So, as a medical educator, this is an issue that's very near and dear to my heart, and this is my personal challenge. Okay, what can we do about this at DMU? Okay, at my med school with my students who are going to be taking care of my community, my neighbors, my state, how can we make a difference with this? So if you look at what we're doing right now in terms of medical education, our students don't have a lot of opportunity to hear what mental illness feels like from the patient and the family perspective. So we teach them, okay, what are the symptoms you need to diagnose schizophrenia? What's the difference between first generation and second generation antipsychotics? How do the meds work? We teach them all of those kinds of things, but not necessarily a lot of time spent hearing what does it feel like to be diagnosed with and treated for a mental illness? What's the emotional experience of that? And as a result of that, our students often get really intimidated by not knowing what to do, right? So if you're in the middle of a psychiatric crisis, you are not really in the emotional place where you're thinking about how to be super nice to your medical provider and think about their needs, right? You're having an emotional crisis, and maybe you're angry. Maybe you're disconnected from reality. Maybe a whole bunch of things are going. Maybe this is the 15th interaction you've had with the medical system in the past 2 weeks, and they've all been bad, and you're mad about it. And so maybe you push back against your medical provider, or maybe you're not following what they're telling you to do. And so our students don't necessarily know how to handle that, right? That takes kind of a different skill set than someone who comes in because they think that they might be having a stroke and they're all on board with whatever you tell them that you want them to do. And so they don't necessarily have the right skill set to understand, okay, what does it feel like when you're in a crisis? What does it feel like when you've been receiving this diagnosis or when you've been involuntarily committed for treatment? What's that experience and how do we make it better? So we wanted to give this to our students to help them understand, you know, what would make this better? What are patients looking for? What do they need? And in particular, we wanted to offer this to our students after they'd been out there on rotations and after they'd seen some of the good and some of the bad. So we run a fairly traditional medical school curriculum at DMU, and historically what med schools have done is you spend 2 years sitting in class, and then you spend 2 years going out and following physicians around in kind of a mentorship model, doing rotations, seeing how it's actually done. So we thought, okay, we know that there are fabulous and amazing and wonderful physicians out there who are compassionate and inclusive and provide truly excellent care. And we all know that there's the other sort out there too. And our students get exposed to both. So we wanted to wait until after their third year, so after they'd spent a year really out there seeing what goes on, and then bring them back and talk about the experience. And so what we did is we partnered with our local NAMI chapter and with our state affiliate with NAMI Iowa to bring NAMI's provider education program to our students. And so 4 weeks ago today, we brought a volunteer subgroup of our students back to campus. We fed them, we gave them housing thanks to an amazing grant from a local group, and we provided the NAMI provider education training. And it was kind of awe-inspiring. So we have a relatively big medical school class. We take about 220 students in each class. And I sent an email out to all of them. Actually, I got my boss, the dean of the College of Medicine, to send it out because he's more important than I am. And he said, hey, who wants to sign up to come back to campus when you could either be on vacation or you could be studying for your incredibly high-stakes board exams? Who wants to come back and give us 15 hours to learn about mental health care? And we had 41 of our students do it. We had fully 20% of our medical class who showed up before they needed to and spent 15 hours doing this. And it was amazing. And it was transformative for our students, but also for the NAMI volunteers who provided the curriculum, who said things like, this has restored my faith in the future of medicine. And our students asked questions and our panelists asked questions, and we had this interaction where it met those goals, where our students heard from someone who carries an incredibly stigmatized diagnosis that gets used as an insult by some medical providers, and our students had heard that kind of crap in emergency rooms and other places. And they got to ask this woman, what's it like? You know, some of this stuff that's happened, or some of these behaviors you have, or some of these feelings you have, what's going on there? And they had this real conversation. And so what we're trying to do is to give students the emotional foundation. We've already given them the knowledge foundation. We do it, all medical schools do it, you have to stay accredited. But to give them the emotional experience of hearing these powerful stories and then sharing their own, and giving them positive role models. So those of you who have done NAMI provider know that there's a provider in the teaching panel who can also share their personal experience. And so our students heard that, and we really worked to create a frame for them early on about how to provide compassionate, collaborative, inclusive care. And we're doing a ton of research on it that we'll talk about more tomorrow, but hopefully making a difference. Thank you.
Thank you. Our next speaker is Angelina Brown Hudson. She's a program director with the National Alliance on Mental Illness of Greater Houston. Her focus is to expand the number of programs, education classes, and support groups available in the Houston area. Come on up.
I tell you, after following the two speakers that were here before, I'm a little worried about this group. They sound very expert-like, and I don't think I'm going to behave, speak, or seem very expert-like in front of you. And one of the things I remember is when I was first asked to sit on a panel called, hearing from the experts, I thought, well, what am I an expert at? What could I be an expert at doing? And what I was reminded of today is I'm probably an expert at avoiding crisis. I'm an expert at stepping into utter collapse. I'm an expert at smiling when I'd rather cry. I'm an expert at bouncing back with resilience. And I'm an expert at writing a new future story when the story that I had written before, I see that it's not going to go in that direction. What I am before you, if not an expert, I'm a mom. I'm probably a sister, daughter, in-law, sibling, aunt, and wife of someone diagnosed as well, but they don't know it. But I can confidently say that I'm a mom of 3 children who are diagnosed, as long as you don't tell the baby son, because he still says it's not him, it's you. This is a path that I didn't volunteer. No one signs up to be a family member of someone diagnosed with a mental health condition. Better yet, no one signs up to have a mental health condition, am I right? But here we are. I have 3 kids diagnosed with a brain disorder, 1 with autism. It took him 7 years to get that diagnosis, but I don't fault anyone. That was 20 years ago. We weren't using that word regularly then. And then I have 2 that have mental health conditions of the anxiety variety, because they have many diagnoses. I won't try to list them all. I speak frequently now because of NAMI to audiences about my experience as a parent of children that are overcoming their health conditions and doing so quite victoriously. And one of the places that I've been to would be the high school environment, talking to children through In the Silence and Parents and Teachers as Allies. And one 11th grader asked me, she said, "Miss, can I ask you a question?" And I said, "Sure." And she said, "Well, never mind." And I said, no, ask your question. It was a psychology class. She said, "You have 3 children diagnosed?" I said, "Yes, I have 3 children diagnosed." She said, "Wow, did you marry the wrong man?" No, it was a psychology class, and she had learned about hereditary and genetic traits that go into families that have these diagnoses manifest. And I said, "Well, honey, I've been married 24 years. There are many mornings I wake up and think I've married the wrong husband." But here's what I want you to know, that regardless of what happens in our lives or who you decide to marry, or if there's an accident or illness or a traumatic brain injury, or it just shows up because of an environmental trigger, you play the hand you're dealt. You pick up the pieces and you try to do the best you can with the information we have at the time. So I'm honored to be here today as an expert on living with family members with diagnosis, others with no diagnosis, some with diagnosis and not accepting treatment. I have 2 degrees, a bachelor's degree and a master's degree, but nothing prepared me for living with a person diagnosed with a mental health condition. Nothing. We are sent home with a prescription and a diagnosis and a brochure. And we're asked to do with those with deeper training in the mental health arena would also be challenged at doing, except they have the books to refer back to. We're asked as family members to know what to do when they refuse treatment. We're asked to know what to do when the police call and say your loved one has been arrested. We're asked to know what to do when security calls you and says your son is downstairs for talking to people and pestering them. But I appreciate NAMI because it was the NAMI classes that taught me how to live with dignity and respect, how to hold my head up in spite of the big challenge that I had to make. It taught me how to have hope for myself, how to build hope in others. I later became a teacher in NAMI Basics. I became a presenter for the programs that we offer through NAMI. I also became a provider education presenter in the hospitals. And I want to tell you, there's nothing more rewarding than now, 22 years in my journey as a family member, seeing new people find hope in the little pages of the NAMI booklets that we share. Of finding people who say, you know what, I didn't know there were other people like me. Family and Friends is a new kid on the block in NAMI programming, and oh my goodness, to see people crying that are in their 60s and 70s and 80s, and they lived with their family members for decades and had never heard of NAMI, sit in those seminars saying, thank you for bringing some dignity and respect and hope to what we've been living for decades and didn't know there were other people who cared. One person from a family-to-family class I taught, can y'all tell I'm busy with NAMI? But one person from a family-to-family class I taught, she was a school teacher. Their son was 28 years old, diagnosed with bipolar disorder and Asperger's, okay? And she said, it was like getting a hug that I didn't even know I needed, just to sit in the class with all the other parents. So I really appreciate for the opportunities that NAMI gives me, but I want to highlight something since I'm on this panel today, and that is the provider education program. Menninger, which is one of the most highly renowned mental health hospitals in the country, invited NAMI, our affiliate, NAMI Greater Houston, to come and do 9 classes of provider for all of their clinicians, psychiatrists, line staff. It was the clinical director, Dr. Susan Hardesty, that considered NAMI's provider education program a part of her patient-centered care model. That if clinicians and providers were going to put their patients first and teach and treat them with that dignity and respect, then one of the things that they all had to have from the front door to the back was provider. And we did 9 classes there with a wonderful coordinator for the program, Dr. Margaret Gallagher, and it was transformational for those physicians. And here's the one thing they said at the end of the several weeks we were with them. This is the one thing that stuck with me. One of the therapists said, this was just as important as my medical background and training. That this was just as significant as all of the other training I had before, because he heard the rest of the story. He understood what the family members went through when the person was not in the hospital. He understood what the person living with the diagnosis was going through when not in the hospital. And he understood what was happening in the weeks, days, and months coming back to the hospital. As a result of that series of classes, we are now invited on a monthly basis to give hope to the parents and to speak through in our own voice to the inpatients. Thank you.
Yay, that was great. Angelina is an expert in my book. Carlos Ferrari is a member of the NAMI National Board of Directors and is an advanced registered nurse practitioner in Miami, Florida. He's also a member of NAMI Miami-Dade County, where he serves in their affiliate board of directors. Please join me in welcoming Carlos Larari.
Good afternoon. How's everyone doing? Can you hear me well? All right. Well, I have to thank Terry. She probably has excuse me, not Terry. I got my notes here. Angela, correct? The toughest job. I always tell my mom, well, my mom always tells me, she goes, you know a lot of MDs and a lot of PhDs, but I'm an MOM. And I try to talk to her about evidence-based care, but she's like all about the mom-based care. I tell her, when she gets down on herself, I try to use a little humor to lighten things up. And I tell her, you got a gay, a cray, and a criminal. One son is gay, one son is crazy, and the other son is a criminal. And the little one isn't really a criminal, he just has ADHD and it was never really treated, so he got a bunch of car accidents and broken bones, but we gotta find humor in these trying times. I'm here to talk about inclusion and compassion in the field, but I'm talking about what I'm doing in the community. It's a pleasure to serve on the NAMI National Board of Directors. It's a wonderful opportunity to get involved with legislative, political advocacy at the national level, but there's still a lot of work I do in the trenches of NAMI Miami-Dade County, in the community. And I want to touch upon some of the things my colleagues said and my experiences doing the work in the past several months. So one interesting thing is I work as an adjunct professor of nursing, and I take my nursing students into a crisis stabilization unit, and the nursing students, point out that there is paint peeling off the walls, that there's no social workers on staff. I'd make the poignant observation that Baptist has a new multi-million-dollar oncology unit. Baptist has a new multi-million-dollar cardiology unit. So I still very much see in the trenches that if budgets reflect our priorities, then we're not prioritizing as a society mental health care. When I ask the charge nurse, well, what can my psychiatric nurse students do? Can they have a group therapy or therapy activity? There's one social worker for 28 psychiatric patients. It's basically medications, breakfast, lunch, and then you go back to the room where you watch TV. I may sound like a broken record because I've talked a lot in the past couple days, but one thing I've thought about and talked about is that medication is often necessary, but it's not sufficient. It's not good enough. We're not investing in a society and within our health systems on psychosocial services, which often get people back to the point of functioning, back to the point of working, going to school in their community. These are things like peer support, family education, therapy, and these are things that we're seeing that I'm not seeing in the healthcare system of South Florida. On a personal note, peer support has been very crucial in my recovery. I shared my story, and I don't want to be too redundant, but it's funny. Matthew's my best buddy. He's my peer support, and his mom is a very keen woman. She's been the person that's made a lot happen in Miami-Dade County. She basically convinced Matt to meet me through bribing him with a tuna sandwich and a matzo ball soup. But she was like, Matt, I know this really nice guy. He works at a deli. Come meet him. And at the time, I was waiting tables. I was going to college credits. I was going to college, community college at night. But that inspired him to reach out and start opening up and sharing his story. Peer support is, I said it earlier, these are day-to-day illnesses and day-to-day struggles. You're lucky if you see a psychiatrist once every 3 months. You're lucky if you see a therapist once every month, but it's still a day-to-day struggle, and you need someone there on a day-to-day basis. In addition, Terry was discussing the provider shortage. If we think about it in the most ambitious in the global context, a place like the United States has roughly 350 million people and 50,000 psychiatrists, and that's not enough. Half of rural counties or half of counties are getting limited access to care, and there's increased suicide in rural communities. My girlfriend's Indian, and she always tells me, it's great what you're doing for the Latino community, but what about Asian Americans? In a place like India, there's 1.2 billion people and 3,000 psychiatrists. So the answer of the solution to increasing access to mental health care isn't going to be solely training more specialists, training more psychiatric nurses or psychologists, but really utilizing the services of lay community workers, of peer support specialists, of nurses, social workers in tandem in the community, providing services where people are where they're at. I encourage you to think about our responsibility as leaders of the free and liberal democracy to not only improve our law and our standing, but also lead the way for low and middle income countries where many people with schizophrenia end up starving in a jail or end up without medication and don't have the privilege that I've had to be able to have access to health care, take medication, and be able to stand before you as a board of directors member, as a board certified family nurse practitioner doing what I think is meaningful and powerful work. Another experience that I have in the trenches, so to speak, where I'm in the field and I'm hoping to try to move the needle towards more inclusion and compassion. We mentioned about collaborations. I do quite a lot of speaking at University of Miami, at FIU, at CIT, things like that. I've seen both the kind of the good and the bad side of it from the provider education standpoint. I remember at my RN education, the first day of orientation, the nursing professor was like, "Oh, you don't want to work psych. You have to be crazy to work psych. You're going to lose your mind if you work there." This was the dean or one of the more well-renowned professors at one of the largest community college nursing programs in the United States. My girlfriend told me she was looking forward to psych, and I was like, "Well, awesome. Are you going to become, one of us? Are you, fascinated by the complexity of the human mind and gravitated to working on the most challenging problems in society?" She's like, "No, we call it psycation. You don't really do anything in the psych rotation." And these are the people that we're training to be responsible for our most vulnerable in society. It's kind of scary. It's not even, there's some humor in my story, but some parts are actually deathly frightening. These are the people that we are holding in charge of taking care of some of our most vulnerable members of society. And really there isn't sufficient education and training. Even in my curriculum to become an ARNP, the psych portion was a 1 day, 3 hour PowerPoint and talk. And ARNPs are going to be very much the gatekeepers, the pathways to primary care in the future healthcare economy of the United States. And there's not a sufficient good job being done yet. So there's a tremendous opportunity for NAMI to embed its provider curriculum or its provider education into the curriculum of healthcare professionals, of nurses, of social workers, of physicians, of psychologists, so forth and so on. Another thing I wanted to talk about, we talked about the challenges with limited networks, behavioral health networks. Staffing is a concern. Again, I think peer support may alleviate that shortage. We talked about the nurses, emergency rooms and corrections or criminal justice often being the gatekeeper to the point of first contact in the system for people who are seriously mentally ill. Obviously not the case for people with other health conditions. But we need to change that. We need to have care occurring in the community. One of my experiences, and it's been a while now, I'm a little bit removed from it, but I worked as a psychiatric nurse in a maximum security forensic hospital. I kind of had a sense of bravado or a sense of naivety where I wanted to do some time in the trenches, so to speak, if I wanted to be a leader in mental health care. And this was a max security forensic hospital, an hour into the Everglades. And, people routinely discussed beating up patients if they got out of line. I thought to myself, wow, if we took a legislator through these halls and they could palpably sense the fear and the violence, like this wouldn't be just a budget. This wouldn't be just a line on a piece of paper. These are people who, for all intents and purposes, the hand they were dealt was a very difficult hand. And we were spending millions of dollars not to get them to the community or restore them to functioning, but to have them stand trial and be restored to competency. One last thing I want to touch upon, two last things very quickly. This one's a bit topical, but we're seeing an immigration crisis at our borders. It hasn't been much of the discussion at the table yet, but we do have to think about mental health services for immigrants and refugees. As a person with schizophrenia, part of the risk was being a first-generation immigrant. Being a first-generation immigrant increases your risk for schizophrenia. I see it in my patients. I serve a lot of Hispanic patients in the Miami-Dade community, and a lot of the conversation we talk about is the challenge of assimilating to this country. We don't have support groups for refugees or psychosocial services targeted for people who are political exiles or things like that. But we have to think about those things and discrimination possibly as some of the risk factors for mental health issues. But I want to be brief with my takeaways. 2 or 3 quick takeaways. Share your story. we are all experts on our lived experience. We can do a lot of good to continue to change the conversation by sharing our stories and listening to other people. Go out there and vote. These are very difficult and trying times. Our votes count. Our votes matter. There's still 20 million or so Americans without health care access. We can do a lot of good by continuing to increase health care access. So, continue to vote. And at the end of the day, there can be no change for us without us. So I want you to continue to advocate for more diverse representation at your NAMI affiliates, and make sure your voice as a person who's a loved one, a person with mental illness, or who has a loved one with mental illness, make sure your voices are heard. Thank you.
All right, 4 terrific perspectives, many overlapping themes. We'll be alternating questions from this room and from the online community. First question.
Yes, thank you. My interest is in the topic of engagement. My population that I'm looking for are individuals who cannot be involuntarily committed. And I want to know what your basic education is to your providers on how to engage an individual, I know many of us have them, who does not feel that he or she needs treatment. We had a particular case in my community in which a 23-year-old young man who was eventually committed with capgras psychosis had to stay in a shelter from May 2017 until March 2018 because the local system could not engage him.
Anybody want to take the question of engaging people? We do have a beautiful report on this. Seriously, while they're thinking about who's going to take this on, there was a beautiful piece of work done on engagement.
I've passed that to my local community and nothing's happened.
Nothing's happened.
Well, if I think I'm understanding you correctly, you're talking about a young man who's been failed to be engaged and is not, interested in engaging with treatment. Is that correct? Well, I can share some features of my story, and again, I apologize for the redundancy if anyone was at my previous flash session, but some of the things that worked for me were, I had no insight. If it was a family therapy session, it was like, I'm not sick, they're crazy, my parents are crazy, I just want to work, I just want a girlfriend, I'm a great man. But getting access to medication did result in the development of self-awareness. I've said it before and it bears repeating, but about 2 or 3 months after I started taking my medication, it was like a light bulb went on, and I had a moment with my mom where my mom said, baby, you have schizophrenia, and it kind of dawned on me that this was something I had to take seriously and had to manage, and it's been a process of, having access to medication, educating myself. I read almost every book out there, from Schizophrenia for Dummies to Eiffel or Turi's book to Ellen Sachs and K. James Redfield. I just devoured literature to learn about it. And then I think what also has helped has been access to role models and access to peer support. And there's a truth to seeing is believing. And when I've met people, either young people or people that are older, that have careers, that have families, that are doing well, and they have a diagnosis of schizophrenia, the self-prejudice of thinking, I'm going to spend my day smoking cigarettes, staring at the screen, collecting Social Security, that eventually began to dissipate. And then I began to see, hey, this is a serious health issue, but I can manage it. And the hard truth is that some people do not develop that self-awareness, or some people, a minority of people, do not respond to current treatments. But the good news is the majority will. The majority can, and we gotta get increased access and increase services earlier on, because it's so much easier early on in the development of these illnesses.
This online question is a variation on this theme. How do we make mental health information, services, screenings more available in minority communities? So it's engaging the community and the minority population. Anybody want to take that one?
I don't want to hog.
No, I just want to agree with my colleague right here. We have gone into minority communities, holding mental health seminars and panels. We invite the director of psychiatry or whoever is responsible for the psychiatric unit at that anchor hospital in that community, and they can talk to the family members. But when you're talking about convincing someone who has a diagnosis of their own or symptoms of their own and there's no insight, bringing in the in our own voice stories, showing them a picture of a better life or a different life if they accept treatment, sharing different treatment forms that are effective, that's been helpful in getting some young adults and adults to accept treatment.
Question? Oh, sorry.
There are two parts to my question. One is about what are we doing to address another minority issue, which is rural mental health access, which is, I'm in a very rural area. Several of the local hospitals have become critical access hospitals. We don't have a large general hospital. The nearest inpatient beds can be 50, 60, 100 miles away. And those hospitals have been closing down their departments. So there's terrible need for this. And what are we doing to really fight the insurance companies? Because I'm hearing about the departments being shut down because they lose money on mental health services, on inpatient services. I don't know if that's a rumor, but the fact is, what do we do to make sure that people can get access to the care that they need, as well as in the community? And I'm a retired medical social worker. I did discharge planning and a disability advocate.
Maybe I can start on that. I know when I was with HCA, many of our hospitals were affiliating with some of the rural hospitals to try and develop support. The number one most requested service that they wanted to affiliate or receive from the affiliated hospital was how to manage the behavioral health, the psychiatric patients in their emergency departments. And the way that we were seeking to do that was telepsychiatry. So we were arranging telepsychiatry assessments to help guide those in the ED that didn't help provide the avenue for treatment. That's one of the tougher aspects in the rural communities is the bed access is so limited, if at all. But trying to provide at least initial reviews, assessment, and recommendations for treatment via a telepsychiatry kind of a triage system, but often those patients were having to travel ways to get treatment.
Thank you.
In fighting the insurance companies, that's an ongoing challenge. As a matter of fact, we got to the point where we had to actually sue some carriers to be able to get some equitable kind of reimbursement for our patients.
Do you have any suggestions on what can be done to do a stronger legislative attack on that? How we can organize to press our legislators to do it for us?
I'm going to jump in on that one, right? So mental health parity is the tailwind for which change in commercial payments is enabled. The Attorney General of each state is taking an interest in that. It's a very powerful tool. So I would encourage your NAMI to connect with your Attorney General in your state to see how they think parity is playing out through the insurance companies. All right, a question from online. How can individuals and families get more transparency from their healthcare providers?
How to get the provider to be more transparent to the family member?
More transparency from individuals and families. More transparency.
If I could just jump in, please. The challenge we have is the paranoia. There's two things that inpatient providers in particular are sensitive to, and that is EMTALA and HIPAA violations, because they receive big fines, and they tend to go too far in the direction of over-conforming to the regulations around that, and don't seek to go into the gray areas that they could operate in. Because like with HIPAA, if the patient would appear to have any kind of implied consent, And then I think you can comfortably move forward with sharing information that'd be vital to that patient's care. But I think, more and more provider education just to get them comfortable with that mid-zone. We're still not there. I was just talking to Mary if there's any movement yet on trying to get more latitude with the privacy regulations with that. But and they're hoping, actually, she said there's a conversation going on as we speak about that in terms of clarification. But right now, I think, as much as we in the mental health community can be educating providers about their compliance under HIPAA, what they're allowed to do, I think that certainly is one piece of that, but it's complicated.
The only thing I have to add to that is you're not transparent until you have a relationship. So with all 3 kiddos, 2 of which have their own relationship with a psychiatrist and a therapist, it took several years to find the right person, the right combination, for them to finally open up and tell the truth and be transparent with their provider. But in the other direction, you're right, provider education is the only thing I've seen where that's happened.
I'm going to speak to it broadly and not with the expertise, technically speaking, of my colleagues. But I've said this, I apologize if it's redundant, but there was a crucial turning point when I was with my academic advisor, and my mom and my academic advisor said, Carlos, we don't have to talk about any of the stuff that happened to you on college campus. And I said, she said you had the right to privacy. And I said, with all due respect, Dr. Clark, I have a Cuban mother. I've never had privacy. And, honestly speaking, though, those conversations, those are what needs to happen. A conversation between academic advisors and students and parents. In another circumstance, I went with my mom to see my psychiatrist, and it was just very reassuring for my psychiatrist to be like, no, it's okay, Carlos is doing fine. I respect his thinking. I think it's rational. I see him as a colleague in his decision-making with what we're doing with the medication, and that just kind of assuaged her concerns. So, having that open dialogue, that communication between all parties in the treatment network, family, school counselors, psychiatrists, the patient at the center of it all, that's critical. We can't let the statutory, stuff get in the way of it if it becomes too burdensome.
Yes.
Yes, I'm a clinician who's a physician, and I'd like to speak to this issue of HIPAA first. There are times where I will never break the HIPAA law, but I have all kinds of imaginary patients who come in my office. And if someone asks me something that's in a patient's best interest, and they are intellectually astute enough to understand that I am telling them, I have had a patient who had certain problems, and I gave them these medications which they were to take this number of times during the course of the day, and it seemed to help them. Now, if they are foolhardy and say, like my son, I don't even know who your son is, lady, but if they are astute, they've gotten the information that they needed. But what I wanted to do was to give a shout out to my medical college, which is Howard University College of Medicine. And there, we take some sort of psychiatry or psychology for 4 years. Every year, every semester. So it is integrated into your education as part of human health. I think that we are doing the audience a disservice when we talk about putting students in certain types of environments. A student has no place to be an intake. Unless they have a deep-seated desire to be a psychiatrist after they've been on the unit for a while, it is impossible to explain to somebody who's not prepared for it. So even though we see psychiatry as a place where we go and chill, it is really part of what you do is you observe people. You learn to use your observationary skills, and they will hold you in good stead no matter what specialty you choose.
Thank you. A question has come up. What is available or being developed for teachers at the college level to help with their understanding of the impact of the risk of the population in behavioral health challenges?
Well, I can't speak to any formal national intervention stuff that's being developed at the college level, but I can speak into another interesting experience they've had recently in the field, in the trenches, where I think we've pushed the needle towards inclusion and compassion. Again, I apologize for redundancy in my talking in the past couple of days, but my best buddy Matthew and Rachel and I, he's my peer support specialist. We got brought together through his mother, not through the system per se. But we played at this event called Aim High at Nova Southeastern University, which was a health fair for high school students who were interested in becoming medical professionals. And these are all very smart kids in all these AP classes. They're giddy, they're joyful, but they're under stress and pressure. And I, opened my talk, try to cultivate some engagement. I asked, who here has a lived experience with mental illness or mental health issues? Out of 50 students, maybe one or two of these high school students raised their hand. After we shared our stories, after we said it's okay to talk about this, after we said, hey, most people are gonna work out just fine, that's the statistical reality, it turned into like a support group for teenagers. They were crying, they were saying, this happened to my brother, this happened to my father. All these kids were finally able to open up. And to speak more broadly to the issue, I think we need to embed, the mental health education in college, in high school, and all along the formal education system. I know NAMI New York, NAMI Virginia have made some way with getting mental health curriculums in high school, and the sooner the better.
Yes.
Thank you. I'd like to address you from the perspective of family. I am a family instructor for NAMI. I help with the piloting of Family and Friends. I also am a caregiver for a adult son who has a severe mental illness, and I'm finalizing my graduate work to become a family therapist. And one of the things that, at least in my travels or experience, that was challenging was connecting with the right type of family therapist, individual therapist. We've talked about CBT here. We've talked a lot about the medical model and medical treatments. But your thoughts and ideas on how to bring forth some more and engage more of the frontliners around the mental health counselors, the social workers, substance abuse counselors, and family therapists.
Well, in many of our trainings, one of the things we share through NAMI are the different types of professionals that one can go to for help. And I know in our area, we partner with Mental Health America, which they produce this guide of all of the professionals that a person can go to seek help. And what I find is that a person may not immediately run to a psychiatrist's office for mental health support. I mean, they may not even go to the PCP for mental health support, but they'll go and talk to a peer specialist. And when people call and say, who can I talk to that might know something about this particular disorder, like DID or bipolar or schizophrenia, if I know someone in recovery, then I'll ask the person who's a NAMI member, hey, would you give this person a call and see if you can lend any insight? So I'm thinking you're asking, how can we get other professionals in the soup of who individuals can go to for help? And I think we do that in our programming when we list the different types of professionals. And I would encourage you to even have a handout of the different types of professionals a person can seek at the end of Family and Friends. We have a resource table at every Family and Friends seminar where we have handouts with who you should contact for help and support.
Lisa, I'm going to call on you. How can we best make a medical care decision when a mental health care provider disagrees with my primary care provider?
So, yeah, that can be can be really
I didn't
challenging.
say they were going to be easy.
I think that, as several other people have brought up, that relationships really make a difference. So I'm going to hope that you have a relationship with the primary care provider and have a little bit more access to that person. So if the family is thinking, okay, the primary care provider is the one who's on top of this and is thinking, oh, this mental health care provider isn't quite getting it, to talk to the primary health care provider about that. And you can even flat out ask them, could you call the mental health provider? Primary care docs are busy, and sometimes a little bit of a nudge can be enough to get them to try to collaborate a little bit more. The psychiatrist is more likely to pick up the phone for a primary care doc. If it's the other way around, then you can ask the mental health care provider to be making the phone call. But I think there it's a little bit easier of a position to advocate as the person living with the experience or the family member, to talk to your primary care doc and play the card of, well, the specialist said this. I guess that's how I'd kind of negotiate it.
Okay, thank you. Dr. Jim.
Jim Hayes from South Carolina. Quick question for Terry. We're trying to expand our local mental health facilities. We have a 59-bed hospital, applied for a certificate of need last year for 120 beds, got turned down, by 2 freestanding independent hospitals. Felt like it was unfair competition, whatever. Anyway, we did not get our new beds. We reapplied. What can we as a community do to gently nudge the certificate of need project, or whatever you call it, con, whatever, so that we can get that increased beds that we need?
Yeah, that's an excellent question. One of the bigger challenges that we have for those states that have a certificate of needs is how they come up with the bed needs in their healthcare plans. And it's always amazing to me, and I'm thinking about our facilities in South Carolina that are just overflowing. The EDs are jammed, you can't get patients placed, and yet in their health plan it shows no need. And it's so incredibly frustrating, and the systems seem to be fairly rigid. I think the areas that we've had success is when we can really engage the communities and the community support. NAMI has an incredibly powerful voice with many of the agencies. And if the community is coming to the legislators and the planning council and can get their ear, and you can use some of the powerful stories that our NAMI members can tell, I believe that is the voice that gets heard. Those of us that are on the provider side, they always think we have some agenda that's not really care focused. And so we're not heard like NAMI and our communities are heard. But it's incredibly puzzling to me how they come up with some of the formulas with their healthcare plan. And if you can challenge that from a formulaic perspective, God bless you. But otherwise, I think the powerful voices of the community are the best ways to combat that.
An online question. What hope and change do you see for improving stigma in corporate America?
I would say that that's about stories. That's about the champions that are here at this convention that are speaking out. That's about all of the NAMI programming where people tell their stories. That's about people just sharing in the course of their everyday life. Yes, I'm living with this condition, or I have done this, that, and the other in order to live well with the hand that I've been dealt. And the more we talk about it, and the more we share about it, and the more people in the public eye talk about it and share about it, the more it becomes okay to acknowledge that this is a normal part of the human condition.
Go ahead.
I was speaking with our new board member. Vanessa, and I thought I had a pretty cool idea, but of course, like, everything under the sun has already been done. But I was like, why don't we have chief wellness officers or chief diversity officers and stuff like that? And she told me some corporations are already doing things like that. That they're understanding that diversity, that employee wellness is good for the bottom line. It's good for the business, as well as it's just the right thing to do. And there's opportunities for NAMI to continue into the corporate space to share our stories and to create a healthier work environment for employees. Stress in the workplace environment contributes to adverse health outcomes, and we need to be there, doing what we do best. Our three pillars are always going to be education, support, and advocacy, and there's still a lot of work to do just in the realm of education and increasing awareness in the corporate spaces is one where we have a long way to go.
Yes.
Hi, I work in a hospital psychiatric facility as a tech and also have lived experience, and I feel like I've settled that a lot this week. But we, as a staff, had a very unfortunate situation with a patient who was discharged. And there was a really horrible incident that occurred, and I can't really go into it, obviously, because of HIPAA. But we really didn't have a comprehensive debrief with our staff, and I think it was something we really needed at the time. I was just wondering if there is any interest among NAMI or anyone to have a crisis debrief team to prevent burnout among staff, because I know for me, it obviously affected me a lot. It's that chronic empathy. But I'm just wondering if it's been thought about or anything like that.
Terry, how did you handle this at your facilities?
Well, I'm thinking about, does NAMI have an interest in doing that? I would love to see our facilities work with NAMI, because NAMI is such a rich resource in such a unique way that they can touch our staff in ways that others have a hard time. But we typically get debriefing teams in, and where they pull those debriefing teams from, I just offhand couldn't tell you. They're usually local. I would love to work with NAMI to ensure that those are teams that have sort of the NAMI mindset to bring to us as we go through that process. But I'm very disappointed to hear that you got root cause analysis. Usually you provide debriefing as our staff go through traumatic events. So I was disappointed that you didn't receive that.
Me too.
Last question in the room. Go ahead.
Hi. The topic of co-occurring disorders, dual diagnosis, is a topic that I've not heard discussed much at this conference this year. It seems like it's the elephant in the room, and certainly my experience with the practitioners in my particular area of the country, for the most part, go like this. It's his problem or it's his problem, and they accept the individual if the individual has the mental illness or has the substance abuse issue, but not the intertwined whole person. Do you have any reaction or comment?
Well, sure. In my first job as a nurse practitioner providing clinical care, the administrator's like, we don't do substance abuse, we don't touch addicts. And of course, that's unrealistic, because dealing with individuals with serious psychiatric illnesses, I had patients that had substance abuse issues. And it also spoke to a broader issue of lack of integrated care. I mean, it was difficult for me to collaborate with the primary care provider of my patients, to order lab work. I was still using paper charts. Behavioral specialists are some of the providers that are least up to date with the technological advancements. And I'm getting off the track a little bit, but to get back to dual diagnosis, there was a great presentation from was it Chris from SAMHSA, getting the name right? Well, the individual from SAMHSA. We have to do both at the same time. We have to integrate the systems of care so that people can get treated for primary care issues, substance abuse issues, and psychiatric issues, and we have to figure out how to do that. I'm speaking to it very broadly, but that's the need.
We developed this idea with Clark Gregg. I don't know if you saw the opening plenary. He's a gentleman who lived with a dual disorder. And, there's a couple of key pitfalls here. We have to be able to do both at once. That is modern comprehensive care. It can't be fix A until we can get to B, because we understand B, we don't understand A, nor the converse. I'm helping the policy team write our response to CMS, which is threatening to drop the requirement to screen people for substance use disorders in psychiatric facilities, which is about the worst idea I've ever heard. And I think it's really important that we stay on this. The cultures are not naturally integrated, and we cannot allow the larger payment bodies and regulatory bodies to let this go. I'm going to bring back Paul Surgener, who opened our session.
Thank you, Ken. I'm just going to finish up with three very quick things, very quick but very important things. Our first is that if you would like a recording of this session or any of the resources that go with it, you can get this from our website, nami.org/asktheexpert. Or you complete a very brief evaluation and you can download the resources. Your feedback is really important because it helps us to identify the issues that you want to hear more about. The second point relates to this. This is that we have our next 2 webinars planned. Our next 2 webinars are Cultural Competence in Psychiatry in September and Tips for Mental Health Caregivers in November. And you can register for those right now if you go to our website, nami.org/asktheexpert. Very last thing is I would like all 500,000 people here to join with me to thank our MC this evening, Dr. Tim Duckworth, Terry, Lisa, Angelina, Carlos, and everyone who asked a question. Thank you very much.
Thank you, Paul.